Great. Welcome, everyone. What I'd like to do is to walk through the agenda, just in terms of, so you know what to expect for the next couple of hours, and just some brief housekeeping reminders as well. So first of all, we're getting started. We'll have our first set of speakers who are going to be describing the Arkansas Behavioral Health Integration Network, which is really just very innovative. Everybody's innovative. It's really exciting to be hearing this. They will be, as all of our speakers will be giving a didactic presentation, and then we'll be following that with question and answer session, and I'll be facilitating the discussion. I encourage you to use the chat function to put your questions in, even though you'll have ample opportunity to actually ask them by speaking. But I want to make sure that we get questions answered. And if we don't know they're sitting in the queue, then we can't address them. So please make sure that you enter your comments and questions in so that we can make sure that they get addressed while we're here all together. We're planning on a 5 to 10 minute bio break at 1 o'clock. I recognize that 3 hours sitting in your chair is a long time. So we'll do a quick stand up, do what you need to do, and then come back to reconvene at 10 after 1, where we will hear from Nellie Burdett and Deb Hurwitz from the Care Transformation Collaborative of Rhode Island, which has done some incredible work around integrating primary care through their SIM work, through their pediatric work. There's a great deal of stuff that we'll be learning about from them. Really look forward to that. Again, another 5 to 10 minute break at 1:55. And then our last speaker of the afternoon will be Chris Barton, who was going to be describing their long-term, long-standing innovations around behavioral health integration through the Blue Cross Blue Shield of Horizon Blue Cross Blue Shield of New Jersey. So very excited about that. We'll have a quick wrap up just before the end, and I really look forward to this. So thanks everyone for participating. And thanks all of you for your willingness to say who you are in the chat. And I think what I will do is stop sharing my screen, and I'll have our colleagues, Patty Gibson, Kim Schuler, and Adam Whitlock start their work. But first I'm going to introduce them. So I'm going to stop sharing. You guys can put up your first slides. Great. Looks good. Okay, well, it is with great pleasure that I would like to introduce all of you to our colleagues from the Arkansas Behavioral Health Integration Network. Kim Schuler is an LCSW, the co-founder and CEO for this network. She provides clinical and operational expertise to primary care clinics and health systems in Arkansas through integrated behavioral health models. She has experience working in both private and public behavioral health settings in a variety of roles, from direct practice to program development and oversight. And she's a passionate advocate for behavioral health and specializes serving multicultural and underserved populations. Certainly important in the current day. Patty Gibson is a physician who is board certified. She's an overachiever, just saying, in psychiatry, addiction medicine, and anesthesia. She is the co-founder and chief medical officer for ABHIN and is a consulting psychiatrist for an Arkansas hospital system primary care BHI team, and is also serving as core faculty for community residency program in Little Rock, Arkansas, where she lives. She is the co-chair of the Collaborative Family Healthcare Association Psychiatry Special Interest Group and is an advisor for the Interprofessional Primary Care Institute. She's been actively involved in integrated behavioral health for more than 10 years, including working with blended integrated health systems in Little Rock and in Oceanside, California. And finally, Adam Whitlock is the manager of primary care for Arkansas Blue Cross and Blue Shield and serves as the leader of a multi-organization and multi-payer primary care stakeholder group that supports the practices across the state of Arkansas, where they have been engaged in this work for many years. Adam is responsible for the day-to-day management of the primary care programs and has worked closely with practices and providers in the state's patient-centered medical home program and the CPC Plus initiatives, and now Primary Care First. So with that, I'm going to hand over, mute myself, and look forward to the upcoming presentation.
Thank you so much, Ms. Watkins, for that introduction. And we appreciate the opportunity to be here. We'd also like to thank our Blue Cross partners for inviting us to participate in this presentation with them. So I'm Kim Schuler, and it gives me great pleasure to talk to you a little bit today about the Arkansas Behavioral Health Integration Network, or as we'll call it in this presentation, ABHIN. We're going to quickly go over some disclosures. I currently, besides being the CEO for ABHIN, have a private practice. I also do behavioral health integration, clinical supervision and coaching, and participate in the CPC plus behavioral health work group as a co-chair. So as we start to talk to you a little bit about this work, one of the things that we wanted to do was share a little bit about who we are. We know that in behavioral health, a lot of times it's the relationship. You'll hear us talking about the importance of establishing rapport with the patient in the primary care setting. And so we decided to take a moment and just share a snapshot of some of the relationships in our lives that are important to us. I want to point out on the bottom right corner, there's a picture of Dr. Gibson and I, and this is where we meet for our when we did meet in person, this is where we would meet for our quarterly stakeholder, multi-payer or multi-group stakeholder meeting. We would meet at the Arkansas Hospital Association, and here we are at our first meeting. So I had to include that.
I'm Patty Gibson, and as Kim said, co-founder with her of ABHIN and am the chief medical officer. I'm also paid by the Baptist Arkansas system to be a psychiatric consultant to their behavioral health integration team that's in some of their primary care practices, and also core faculty of a newly forming residency program that's a partnership between the medical school and Baptist Health, and really looking to integrate behavioral health in these residency programs. I also serve on the medical advisory committee for Qual Choice Centene. And these are really the relationships that are super important to me. And you can see that my dog is front and center and he's on the back. But this says a lot about, you know, my son and his wife, my husband were huge Saints fans, and that is Greer's Ferry Lake behind my best friends and I, where our headquarters is. And the picture in the bottom right is my behavioral health integration team with the Baptist system. And there's a combination of LPCs, CSWs, LMSWs, and mental health RN. And I think building a team and the relationships between the team really help improve the effectiveness of what we all do every day.
Absolutely. Relationships are so important. So now we're going to tell you a little bit about what is ABHIN. ABHIN is a technical assistance center. And then the next question is, well, what do we do? We provide support and training to primary care practices. We also facilitate change. We build capacity of both organizations and individuals, and we provide statewide, local, and virtual trainings throughout Arkansas. Our preference is in-person training. However, we have adapted, as everyone else has this past year, and we've provided all of our resources virtually through Zoom. So today on the agenda, we're going to talk about our story, the lessons that we're learning, and our future. We have this quadruple aim slide up because we want to talk a little bit about, this is really the foundation for what we're doing. It was a premise of how we started, how we formed, and really the quadruple aim is driving us as we're looking at development and our projects. So, as we've just said, ABHIN is an independent local organization. one of the unique things about our organization is Dr. Gibson and I both have worked for extended periods of time in behavioral health integration in direct practice, and have a lot of experience working in primary care practices and walking with them on the journey of how do we implement behavioral health integration, and also addressing some of the frustrations that can come along the way without appropriate training. One of the things that I feel is really unique about us and our organization is the stakeholder support. We're fortunate in Arkansas to have a cohesive team, and everyone along the way has talked to us about what are specific needs for behavioral health integration across the primary care continuum, and really helped us in developing that process. The other important piece of that is primary care practices. We have amazing engaged primary care practices who really attend trainings. They are very vocal about what are some of the needs. They ask lots of questions and really help guide us in our development of what are some of the specific areas that we need to be addressing. So as we said, we are fortunate in Arkansas to have amazing people on our team. I wanted to tell you a little bit about how we've started. So we started as a CPC plus stakeholder group, and we started meeting about 2.5 years ago. And we're so fortunate to be invited to attend this multi-payer stakeholder meeting. And I live in the northwest part of the state. So for me, it's about a 3-hour distance. And I thought to myself, this is really exciting. It's something great and that's happening in our state. I'm really passionate, but wow, you know, that's quite a distance. And I started to realize and think about what can really happen, and will I be able to contribute any valuable information? And so after I went to the first meeting, I realized we are doing amazing work in Arkansas, and primary care practices are really changing the way they provide care. And we're looking at care from a whole perspective. And I was intrigued from the beginning and realized, yes, this is such a critical meeting. It's even worth a 3-hour commute. So we have this slide about how we love meetings, because I think what happens is a lot of times we go to meetings with a good intention. We all have something to share and we all have good information, but I don't know about you. A lot of times I leave meetings thinking about, okay, what did I take away from that meeting and what are the next steps? Well, we're proud to say that when we met as a stakeholder meeting, we really came up with an important outcome, which is the Arkansas Behavioral Health Integration Network. So we started as just this volunteer behavioral health work group because we identified there's unmet behavioral health needs in primary care practices. And we then decided, wow, there's a huge need, and it's not going to just be an hour of a monthly meeting where we're going to go ahead and resolve and solve some of these issues that have been puzzling the healthcare system for years and years. So we developed our nonprofit. And here's a little bit of a timeline to illustrate. You could see in 2018, that's when our CPC stakeholder group formed. However, for several years prior to, there was a lot of early research on behavioral health integration and the importance of behavioral health integration. I personally worked in community health the earlier part of my career and really spent a lot of time realizing, you know, we're having a lot of access issues. We can't get people in for 2, 3, 4 months for the care that they need. And this was a specialty behavioral health setting in community mental health. We noticed there's a really high no-show rate. We could say, you know, sometimes 40 to 50% of the time, we were having no-shows in specialty settings. We know that there was high stigma that people were telling us one of the barriers to receiving behavioral health was the stigma issues. And so I had the opportunity to meet Dennis Freeman with Cherokee Health Systems. He is one of the pioneers of behavioral health integration, has done a lot of work in this area. And he came to the community mental health center that I was working in, and he talked about this great new model, PCBH. And I was intrigued from the beginning and thought, wow, this is really a way that we could provide more behavioral health services on a larger scale to people struggling with behavioral health needs. And maybe we could identify them and provide short bursts of care without a long-term model. So I became really interested at that point. And in 2009, I started working in an FQHC and had the opportunity to develop and implement and operationalize a integrated behavioral health program, and then became all along, I was doing direct practice. So I was growing the program and providing the direct services, but really learned firsthand the importance of this work. And Dr. Gibson, she had the opportunity in 2009, she started working on this PCMH model at the VA. And she was an integral part of starting this program at the VA in Little Rock. And since that point, we've both been working in the behavioral health integration arena. It's been a passion of both of ours, but we didn't connect until 2018. And then you saw really early 2020, we became a nonprofit. And at that point, we really started to have the ability to make this more of our life work. And you could see in the present, we're providing CPC Plus trainings to primary care practices throughout Arkansas, and not just primary care practices, but any individual and or organization that is interested in our resources. They're available statewide. On our journey, we have come across many wonderful, influential people. We had an opportunity to attend a conference in Idaho, and it was the IIBHN conference. And as we were listening to them and listening to the work they were doing in Idaho, we thought, wow, if Idaho can do it, can't we do it in Arkansas? And they've provided us with support and encouragement. They've reached out and helped us with writing a grant and really getting us started. We've also attended, and one of the things that's been a great resource for us is the CFHA conference. They provide trainings every year, ongoing trainings. Dr. Gibson serves on a work group, chairs a work group. And so we have a lot of contact with people who are talking about behavioral health integration on a national level. Our goal is to think globally, but bring this locally, so our practices are getting the information that's happening nationally, and we can talk about what are the possibilities in Arkansas. And so we're using this as ways to mentor and brainstorm and bring home resources locally. This slide is from our initial planning meeting. We're proud of that because at that point we were thinking about a puzzle piece. And at this point, the pieces of the puzzle were really fragmented, but we really realized this is important. Piecing it all together. This has been a journey for us. One of the things that we know is we have the stakeholders piece on the bottom, but I really wanted to highlight that our stakeholders have been a key piece of what we do and how we do how we perform the services that we do. I've got to say, in the early beginning, I remember talking, to Adam, Alicia, and Missy several times in our work groups and sitting down saying, we've identified these behavioral health needs. Would you like to co-lead this work group? I don't know. I don't know what kind of time commitment that will be like. I don't know how I can contribute to this. And they continued to encourage us, especially along the process as we started to talk about, we have these great ideas. We're thinking about becoming a technical assistance center. Is there a need for this in Arkansas? We have payer representation on our board. We have patient and clinic representation on our board. And so that's really a driving factor for us as we're looking at what kinds of programming and training are we going to be providing throughout the state. Our vision is better health for all through integrated solutions. And we truly believe that. We have been working on building relationships and acting as a bridge to provide best practices and resources through education and training to all the participants that we serve. Here's some of our core objectives and activities. As I said earlier, we're a technical assistance center and we do provide training opportunities. One of the things that we're doing, and we'll talk more about this later in our presentation, but we're trying to develop local expertise and equip our primary care practices with the skills needed in order to deliver behavioral health integration in their own clinic. We have a large professional network across the state. It never ceases to amaze me on our calls that we have people from all across the state who are joining us. Policy and advocacy is a huge piece of what we do in advancing integration. This map represents where Patty and I are, where our headquarters is, and the clinics that we are working with up to this point. We continue to think about projects to include other clinics. We hope to reach across the entire state. Right now you can see where we are. One of the positive things that we have realized is once we start a project with a clinic, they'll talk to each other about the work that we're doing, and they'll say, hey, did you know this is what's going on? Or, hey, did you know there's a training on this? Or here's some resources. And so for me, it's been extremely positive to see that they're spreading the word, they're sharing their resources, and they're really incorporating the resources into their everyday practices. Arkansas is a rural state, though, and we know that we're going to need to be working innovatively to try to reach those rural areas. So, what are the activities that we're doing? Well, we've been pretty busy since we became a nonprofit. I told Patty I left private practice and didn't realize how busy we would be, but we're extremely busy and we feel very fortunate. We've written several HRSA grants, but we've had 2 grants that we've been awarded, one for opioid use disorder and the other for intervention, prevention, and post-vention. And one of the reasons that we focused on these 2 areas is we hear from clinics that when they're doing a screening and someone presents and they have suicidal ideations, it can be really upsetting. And so how do we help them learn to manage a crisis internally within their primary care clinic and just equip them with some skills so they feel confident in managing the patient until they do make a referral. And of course, opioid use. Arkansas is not immune to the opioid epidemic. And so we felt like that was really, really important for us to key in on that. One of the things that we're hearing actually, last week, we had the opportunity to go out and do our first site visits. Since COVID's been happening, everything that we've done with practices has been virtual. But we felt like people are starting to get vaccinated. There is a higher comfort level. And so last week, we actually went out across Arkansas, took a road trip, and we had the opportunity to interact with practices and hear from them firsthand on specifically what are some of their needs. We've heard a little bit about their thoughts about behavioral health integration, but I think that it was helpful to me to get to see the clinics when we're talking about workflow, to actually get to see how the clinics were set up, what the workflows looked like. Several clinics asked us to go over their suicide policies. And so we feel like we have this opportunity to really provide some hands-on training. One thing that's really important for us that we do is really this started before we actually became an organized nonprofit. About a year and a half ago, maybe a little longer, we started to invite speakers to come and talk to Arkansas about behavioral health integration. And so we've had a whole different variety of national speakers that have come and talked to us on specific topics, everything from what is integrated behavioral health, what does it look like in primary care practices, development, implementation, and sustainability. And Dr. Gibson will talk a little bit more about that. A recent development for ABHIN has been we've developed a pediatric work group. One of the things that we're hearing is with behavioral health integration, there's not a lot of access in the pediatric side of things. And so there was a huge interest. We are fortunate. We have a wonderful interprofessional team that meets together monthly, and that consists of child psychiatrists, pediatricians, psychologists, social workers, counselors, policymakers, administrators. And the purpose of that is really to talk about what are the pediatric needs and how do we adequately represent them and how do we provide training. We were asked by the Arkansas Department of Health, the Office of Rural Health and Primary Care, to write the section for their 5-year needs assessment on behavioral health integration. And that leads us to the work we're doing. We continue to do this amazing work with the CPC Plus Stakeholders Group. We participate in the quarterly meetings, but what we have done is we've recently provided a 3-part behavioral health integration series. We just did this in March. And so we had a lot of wonderful feedback, and Dr. Gibson will highlight that. Here's our website, ABHIN website, www.abhinnetwork.org. Please check us out. You'll be able to see the great work we're doing in Arkansas. We have our webinars recorded. They are on there with PowerPoints. We have links to articles on behavioral health integration, updates on projects, and we're really excited. One of the things, just to highlight, we also make all of this information available to primary care practices in Arkansas so they can access all of this information. Thank you so much. And at this time, I'm going to hand it over to my partner and friend, Dr. Gibson.
Yes, it's been fun for us to get ready to do this presentation, because you get in the weeds of what you're doing day to day, but it's been fun to look back and put the timeline together and all of the things that have happened. And it really has been a transformation and progress of change, and really liked what Dr. Watkins in her blog on the Milbank website this summer talked about. It's been a decade of commitment to primary care transformation, but starting to yield positive results. And this data comes from the Arkansas Blue Cross Blue Shield data that was also published in issue brief in July. And you can see that the trend of return on investment is beginning to become positive after some initial expenses. So this is from the issue brief, and we've got the link there. You probably are all very familiar with it, but our partners at Blue Cross, Alicia Burkmeyer and Adam Whitlock, along with the UAMS, Dr. Brown, Dr. Tilford, published this. So it's really fun to see this data demonstrate the return on investment and the per member per quarter savings, and to just see how it stepped through so that there's still an average saving and return on investment, but how it becomes accumulating over time. And from my perspective, to notice that this has been done and been very successful without really significant effect from behavioral health integration that could happen. From our experience across the state, practices have not been able to implement behavioral health integration to the extent that would bring the savings and return on investment that has been shown in research outside of Arkansas. Some of the pieces of that, it's not that our practices haven't been trying, because they have, and we've definitely seen progress. Part of when you're looking at the big picture, bringing up this driver diagram, getting ready for this, I realized, I've never really looked at all the pieces of this driver diagram and how complex it is, but how accurate it is. And so it made me realize, if I haven't even looked at it, then the practices, the primary care doctors, the care coordinators, they're not really appreciating the details and the wisdom that is just in this diagram. And part of the wisdom of CPC and what's put together is bringing some of the evidence for all of these pieces, but specifically behavioral health integration. They've done a good job. And one of the places to start is the definition of BHI. People misunderstand and often think behavioral health integration means getting a mental health specialist and putting it in your clinic, and they continue doing what they've been doing. But behavioral health integration is transforming the way primary care healthcare is done. It's the primary care team and working with behavioral health practitioners. We've got to still overcome that separation and the barrier between primary care and the behavioral health providers. And it's not just doing the same old thing. It's a very systematic, cost-effective population approach, which is very different than specialty mental health. The CPC Plus implementation model did a great job of presenting to practices the two options, which are the two best evidence-based models for behavioral health integration. And that is the care management model, which is really the collaborative care management model that has been published. There's been more than 90 randomized controlled trials, and the AIMS Center and University of Washington have this very well published. There's codes. And so that was one option. The other option is a primary care behaviorist model, or PCBH. This is a great job that CPC Plus put it out there, and most of the practices on their reports have said they are doing one of these models. The thing is that they're working hard to do it, but they are not doing the models as the evidence has been published. Specifically on this care management side, a lot of times they're saying that they're providing care management, but it is with their care coordinator that is providing chronic care management. It's not necessarily someone that's had behavioral health training. It's very rare to find a psychiatric consultant involved in this care management. In Arkansas, there is very few, and I'm sure less than 3 psychiatrists involved in practices. And some of that's been part of research studies that are being done. So practices have been doing some of this and working hard, but not doing it to the extent that it shows the evidence that that BHI does accomplish the purposes. The primary care behaviorist model, most practices have tried to hire someone and put them in their clinic. But the key is here when it says evidence-based behavioral treatment customized for primary care. This is definitely not the same thing that's being done in traditional mental health settings, and practices and behavioral health consultants are having to learn how to do that. So how do we stay motivated and continue to make the next steps? Because we've definitely made progress, but we need to continue to make progress if we're going to take this to further fruition of what could be accomplished, and not slide back. There is concern from the practices that when CPC Plus ends, that they're not going to get the same sort of support and coaching and training and support that they've had through the CPC Plus program. We've gotten a lot of information from the practices about their concerns and about what they have done and about what they want to do in our involvement with some of the CPC Plus training. So in October of 2018, we had an in-person training that we were involved in. In December, we had an online CPC Plus training for behavioral health and integration implementation. And in that training, we realized from the feedback from the practices, we needed to give them more intense information. And so we developed, along with our CPC Plus trainers, 3 weeks of training back to back. The one on development was kind of starting if programs don't have a program going and what things they need to look at. In the middle was the implementation pieces, how to build on what they've done, and then the sustainability piece. And the green comments are after the last meeting, that people were happy about it. There was good attendance, but there's still a need for more and more training and to understand how to really implement the model. This clinic feedback is from some of the clinics we work closely with in our grants, but also some of the clinics we've gotten to know through CPC Plus, that there's still themes of needing more training for the clinics, for the BHCs, but also there's billing and coding issues. How are we going to financially sustain this when we don't have the fees that come through the value-based programs? There's even in the weeds issues about HIPAA documentation, sharing of records, and then again, getting the PCPs to buy in as well as clinic staff. This was a very brief informal survey that these were the exact word comments that came from practices about still needing buy-in. We've done a lot of transformation around the primary care doctors. Teams have grown up around them, but we're still needing more training and engagement of the doctors and of the clinic administrators. They know these things are a great idea, but when it comes down to the weeds, it really is kind of like getting COVID vaccinations. Everyone's now understanding the science behind it. And nationally, we know it's a good idea. But when you start looking at how do we actually implement this day to day in a state, in a practice, it's challenging. There's still lack of understanding of the return on investment and what's the financial sustainability. So it's really great to see the research that our Blue Cross team has published. So what's our role? We see our role as kind of bringing in the global, the evidence, the national research, and then bringing it home to be relationships. That it's not just the University of Washington says this is a good thing. It is through relationships with Patty, with Kim, with Adam, with Alicia. It's really has to happen one-on-one and not just one time watching a great webinar, there's a lot of training out there, but it takes coaching. People have to be able to come back and say, we tried this, what help do what can we do now? So this is where we see ourselves is experienced, bringing in the national evidence, but then being able to help people, individuals, as well as clinics. And the other piece is advocacy and awareness. And the picture at the bottom is Kim and I with Dr. Kent Corso, our consultant on suicide assessment and training, and when we were down at the Capitol last week when he was in town. So we really do see ourselves as wanting to be involved in sustainable transformation and have several things we'd still like to develop in terms of expanding our website, creating a national conference, and training in the state. There's been a lot of good things happen it's a little bit scary to think about how things are going to change as CPC Plus changes, and then the pandemic bringing in all new challenges with mental health. But there's definitely light and hope and light at the end of the tunnel, and it's exciting to see how far we've come with our partners and teams. So that's wanting to try to finish to give people time if they have comments, questions, discussion, and we appreciate the chance to be here.
Thank you so much, both Patty and Kim. This has really been wonderful. I love that rainbow. It's gorgeous. So I also wanted to just give our colleague Adam Whitlock a chance to make a comment. And Adam, I didn't have a prepared part of the presentation, but did you have anything you wanted to add to what Patty and Kim have shared with us?
Sure, thanks, Lisa. I just want to say thank you to Dr. Gibson and Kim. As we got started with the stakeholder group, they were some of the first people that we came to participate, and especially knowing Kim's geographic issues there at a 3-hour trip. It was a Friday afternoon meeting ending at 3 or 4 p.m. So it's a long trip home on a Friday afternoon. But she stuck with it, as obviously did Dr. Gibson, and so just thankful for their input. If you're thinking about why was this successful or how is it successful, I think it goes back to the stakeholders that we had in the room. As a payer, we can only affect certain things in the healthcare system that are specific to a payer, but Dr. Gibson and Kim were in the field doing the work, and so they bring their unique perspective and experience. We had hospital association there from their experience. We had patients in the stakeholder group, and all of us combined, along with other payers and other organizations, came up with behavioral health as an important need to address in the state. And so thus formed the Arkansas Behavioral Health Integration Network. And Dr. Gibson and Kim have taken that and just run with it and are doing so much. As a payer, as you guys know, we can provide all sorts of data. We can slice it and dice it and filter it however we want, but clinics don't always know what to do with that data to make a meaningful change. And this is where ABIN comes in and is able to bridge that gap for these Arkansas clinics. And so we're just in the beginning stages. They're being successful and looking forward to more success in the coming years.
Great, thank you, Adam. So we have a couple of questions that came in on the chat. I guess we'll go to those first, and then if others have questions, either type them in or feel free to just speak up. So from our colleague Deb Hurwitz, who we'll be hearing from shortly, she was curious how you got TA designation, both approved and then available through HRSA.
Sure. So really with that process, what we did is to become a technical assistance center, the first step for us was to become a nonprofit. And so we developed a board. We started meeting regularly with our board. We probably did that for about 6 months or so before we became or received our 501c3 status in the mail. And then we started to apply for HRSA grants, and we wrote in the functionality of providing technical assistance on these projects to primary care practices. And so we were grateful that we were approved for those. And since that time, we've been providing those services.
That's great, thank you. And is it, and you said it's for all primary care, it's not just FQHCs that you have to focus on necessarily?
Correct. What we did is we invited practices to participate with us, and it is, a process. They have to make the time commitment. that they're willing to attend monthly consortium meetings, that they're willing to participate in the pieces of the project, willing to at least explore and try implementing some of the different ideas and functionalities, but they've been fantastic. And so we're 6 months in on both of these grants, and we're at the stage where we're starting to expand our consortium. And so at that point, we'll be able to invite other primary care practices to participate and join us.
Thank you so much. That's terrific.
Yeah,
Good for you.
thank you.
Thank you for your question.
So I have another question in the chat from Dr. Shank at the Health Collaborative in the Ohio, Kentucky regions, and I'm specifically asking, can you speak more to the 2 different models for integration? So there was care management versus a specialist model. How do they operate differently in the practices, and do you find that the rural practices have fewer options, just sort of as a practical question? And then a third part of the question, do they operate in tangent sometimes where you have both models in operation?
Yeah, that's a great question, and it is debated by different people in different parts of the field. But the short answer is they are very different. They can fit hand in glove together. They can definitely be complementary, and practices can do both. Sometimes you need a different team, sometimes the same. Let's say you're using an LCSW as your behaviorist. That LCSW can also function as the care manager as part of the collaborative care management role. But sometimes you have different team members. At the VA and in the military, they call it having a blended model where you actually have both models. You have a psychiatrist involved, and then behaviorists who are located in the clinics, and they may be psychologists, social workers, therapists. And then the care managers in the VA, they tend to be remote, either by telephone or televideo, but the care managers can be on site. And you're right, with rural practices, it can be a challenge. On the one hand, you would say, well, it's pretty easy now. We can do telehealth. And the thing about mental health and telehealth, it definitely can, most mental health treatment and therapy can be done via telehealth, especially televideo, because if we can see each other, then we can get a sense, and it has been shown to be safe and effective. But one of the things, we keep talking about relationships, one of the issues is that when patients are referred to mental health, 75% of them never go to their first appointment, and it's because of stigma and they don't have a relationship with that mental health person. So that's one of the reasons why behavioral health integration works. It's having a team member who is in the clinic with the primary care doc. So we are still trying to work in rural clinics ideally would be to have that behaviorist or someone in the clinic right alongside the primary care team. But we're hoping that with time, we could also have more of a virtual behavioral health team, that the primary care team can say here and do a warm handoff with the behaviorist virtually, but the patient still being in the primary care clinic. And there have been some behavioral health integration programs that are being done virtually. So I'm happy that's a long answer to actually a long question. We could probably talk an hour about, and I'm happy to talk more if anybody has any questions about it. But it does get into the nuances that if whatever you're trying to accomplish, if you're trying to accomplish saving money, increase primary care provider satisfaction, increase patient satisfaction, a population health outcome, then you need to not just go into a practice and do what feels right, but to follow the evidence-based models. And that's where practices are struggling. If you don't have a BHC that has training, they don't understand the model. And then the practices don't understand the model because they want to say, here, you're a mental health person here. Let you go ahead and take this patient, as opposed to let's work as a team and take care of this patient as a team, or let's take care of this population of patients as a team.
Very helpful. Thank you. I appreciate the long answer to my long question. And I may take you up on that hour-long discussion. So I'll see.
Definitely. Feel free to give me a call or email.
Any other questions for our colleagues? I have a few I would be happy to ask, but I want to make sure others have a chance. So I want to ask some questions around some of the topics of our day. Certainly, we are all still living through the coronavirus and COVID pandemic. And you did, in your answer to Dr. Shang's question around telemedicine and the, frankly, the sort of elevation of that in the sort of appropriately, because it was such an important tool when we were really unable to have people see anybody in person, even family members. And so just your impression about how smoothly you feel that transition has gone, because there's a whole learning curve side to it. And then there's also just the what you see as the sustainability opportunities for this, and what kind of balance you would. I'm sort of asking you to go on a limb a little bit, but what you feel would be the appropriate balance, because I think everyone is. These are payers mostly on the line who are thinking about how to provide support for primary care practices. Mm-hmm. And then the other piece that it may be part of this is just the equity lens that I think we are all appropriately now looking through, which I think is not new, but certainly increasingly relevant to all of our work, and just sort of your views of that.
Mm-hmm. One of the things, Arkansas is a whole diverse population, and we've already seen some of the people who are trying to do school remotely, that they don't have good internet access. I mean, the state is trying to improve the access to internet. So if you don't have good internet access, you really are, that's going to just prevent you from doing telehealth services. We're hoping that by having the patients in primary care practices, that might help with that. But then the primary care practices have to understand it's worth giving up a room that they couldn't bill for patients to let the patient have a mental health visit. So I think the transition has been good in terms of a lot of evidence is there. You can do mental health treatment via telehealth, but, and we're learning all the details. But I think one of the things for people to remember is by all of these companies that are growing up, there's all different names of private companies that are providing telehealth, mental health telehealth services, and they're all over, and the providers are different places. They're not an Arkansas therapist or an Arkansas psychiatrist, but it's the patient is in Arkansas, but these services are being provided by providers outside the state. The doc on demand type of thing. I think that there's still going to be a real lack of engagement of patients with telehealth clinicians who are not, that they don't have a connection with. That's one of the issues why patients don't want to go to a specialty mental health, because they don't have a connection with them. The other thing that they often complain about is they went to see a therapist or a psychiatrist, but then they left, and then they have to change again. And so I think we need to be careful of thinking we can't build a system that is a national doc on demand, pulling doctors and providers from different places and thinking that's going to provide all the services that our patients need. They still want their local staff, their local doctors, their local providers, and especially when they're talking about mental health issues, I think it's not going to be as big of an answer as we hope it will be. We're still going to need some local connections to make that work.
Absolutely. I was going to add that telehealth is such an important piece. When we first started our behavioral health work group in 2018, that was a question that we had. Could we add telehealth services as a way to potentially treat more patients with behavioral health integration and or just in general, especially because we are such a rural state? We didn't know that in 2019, when the pandemic hit, we would have an opportunity to really test out and experiment in how this would work. One of the things that we are hearing from practices, especially some of the rural practices that we visited, was that patients are really liking telehealth visits. They have quickly made the change. Most people have a smartphone today, and so sometimes they're having their visits on their smartphones. Sometimes patients are too comfortable, and you know, they haven't gotten out of bed yet in the morning, and they're still having their visit. And so this is some of the feedback that we've been hearing about practices. I definitely think that now that we have taken off taken off the rose-colored glasses, we can see telehealth is going to be such a critical piece of what we do. It's going to be an additional, in my opinion, an additional tool to provide important care to patients, especially in rural areas.
Thank you. That's great. Well, we are just about at the top of the hour. There's one quick question that came in also from Dr. Shank, and saying that many of the payers themselves have their own care managers that work for their organization. And is there any experience that you have had pulling them directly into the BHI implementation? Or if it's payer supported, then that's another question.
We are aware that there are payer care managers, and I think just nationally hearing about the payer care managers can definitely be involved in improving behavioral health issues and concerns. And but it's still bringing everybody to the team. I think they can be part of the team. It'll be important that the payers who have care managers also recognize that their care managers still may need some specific training around how to do good care management related to mental and behavioral health issues. We have such a split in all of our medical training that we go in and we're either mental health or not mental health. And so even some great care managers, they often are avoiding the mental health or behavioral health issues and not realizing what could be done. Or so providing them more training will be important. But I think we haven't fully recognized bringing in the payer care managers with the clinic care managers as well. We could do a lot more with that.
Thank
I'll
you.
just quickly add from
Yeah.
a Blue Cross standpoint, we're right now in the process of laying groundwork with our primary care first practices for collaboration between clinic care managers and Blue Cross care managers, specifically around behavioral health. So we're getting started.
Great, thank you. It's exciting. We'll look forward to hearing more about that. Well, once again, I want to have big round of virtual applause for Dr. Gibson, for Kim Schuler and Adam Whitlock for sharing their experience, which is really wonderful. We are now going to take a brief break, and we will resume promptly at 1:10 p.m. Eastern time. And we'll be hearing from our colleagues in Rhode Island. I'd like to, with great pleasure, introduce our next speakers. We have Dr. Nellie Burdett, who has 15 years experience with integrated behavioral health, clinical and leadership roles. She has created, led, implemented, and shown sustainability of integrated care programs at FQHCs, community mental health centers, and the VA for a wide range of populations. She's had multiple positions in senior leadership, both providing clinical and policy leads, and we are really delighted to have her with us. Her current roles are as Associate Vice President of the Integrated Behavioral Health at Providence Community Health Centers, which is the largest FQHC in Rhode Island. And she also serves as Senior Director of Integrated Behavioral Health for the Care Transformation Collaborative of Rhode Island, the CTC-RI. You'll see that. And you can see their logo up here as well. We're very happy to have her join us. And her partner in crime for this afternoon, my friend Deb Hurwitz, who is an MBA, BSN, RN, also the Executive Director of the Care Transformation Collaborative of Rhode Island, and she provides strategic execution and oversight for the state's multi-payer comprehensive primary care transformation initiative. As a little bit of background, the CTC Rhode Island is co-convened by the Office of the Health Insurance Commissioner, which is a unique part of our Rhode Island state government, and at the Executive Office of Health and Human Services. Deb and I have worked together closely for many years on a lot of this activity, and I'm really very excited to have both of them join us. So it looks like we already have a shared screen from Dr. Burdett, so I'm going to hand it over to you. Once again, just want to remind everyone to please use the chat function to make sure that your questions and comments will get noted. We will pay close attention and make sure that we can get everything discussed. And also, when the presentation is over, we'll have an active Q&A, and we'll be able to ask questions verbally as well. So with that, I'll hand it over to my colleagues from Rhode Island.
Great, great. Thanks, Lisa. This is Deb Hurwitz. I'm going to just do a little kickoff here and then hand it over to Nellie to take you through sort of the really exciting work that's being done in Rhode Island around integrated behavioral health. But I know that there's some new folks who have joined this multi-stakeholder, multi-state collaborative here. And I thought I would just take a couple of minutes to talk about the Care Transformation Collaborative, because I do think that structurally, how states can think about organizing themselves, as we just heard from Arkansas, is really helpful. And so I'll just give a little bit of that background here as well. So you mentioned in the intro that we are co-convened by 2 state agencies, and that's really kind of a unique and important feature. Rhode Island's been involved in patient-centered medical home or primary care transformation work since 2010. So we're going into our 11th year of, practice transformation, primary care, PCMH first, now sort of focusing on comprehensive primary care and filling in the capacity issues that we've identified along our journey, which integrated behavioral health is one of them. And we call it community health teams dealing with social determinants of health is another presentation for another day. But So we've been around for about 11 years and incorporated as a 501c3, a not-for-profit public-private partnership in 2015. And again, co-convened by 2 state agencies, EOHHS and the Office of the Health Insurance Commissioner, which we call OHIC. So I might slip into that through the presentation and say OHIC, that's our commissioner, health commissioner. And I believe we're still the only state in the country that has a health commissioner. And we're really lucky that we do. It's really been helpful. And you'll see how it kind of plays into really driving, informing, how we're able to inform policy and drive some policy changes. We have a large board of directors. They are a multi-stakeholder group of health plans. We've got all of our health plans at the table, primary care leadership, hospitals, ACOs, Brown University academic, and employer representation, as well as an organization that represents for us, people with a lived experience. So we have, that some perspective, probably not as much as we would love, but we have some perspective from the patient perspective. So that's kind of how we're structured. And, similar to, I'm sure, what you would imagine, where our vision is, that Rhode Islanders would enjoy excellent health and quality of life. And our focus is around transformation of primary care in the context of integrated healthcare systems. And I've talked already about how we try to bring everybody together to really, implement, evaluate, and spread models of care that are, paid for and are sustainable in terms of building out comprehensive primary care. We'll go to the next slide, Nellie, thanks. The goal is very similar, right? Our quadruple aim, but we kind of added another here, which was really about increasing capacity. As we went along, we realized that PCMH was not sufficient and that we needed to really look, and we, identified in our 11-year, journey, those gaps, and behavioral health was clearly one of them. So, we call it out, specifically for ourselves, that capacity and access to comprehensive primary care is a goal for us. This is some of the work that has transpired over time. We've worked with 128 primary care practices, both adult and pediatric in PCMH transformation. About a third of those have now gone through the integrated behavioral health program for both adult and children. And Nellie will talk more about that. Those practices have about 800 providers, adult and pediatric providers in them, which is, just short of, the 1,100 total in the state. And they see about 2/3 of the population of the state. So, we have pretty, significant depth and reach in terms of population health, not only panel population, but big population. All of the health plans help to support this program. So, we talked a little bit about the Arkansas TA. We do some very similar work, and we are fortunate to have support from our health plans. We also have all of the federally qualified health centers have participated in CTC's 3-year transformation program. So we're really lucky about that. And in 2016, we were able to show some significant decreases in total cost of care of our PCMH practices versus our non-PCMH comparison group. During that journey, as I mentioned, our group identified behavioral health as a real issue. And, a little bit similar to the Arkansas story, we brought people together, and there was a really lot of interest in coming to, a meeting around building out the business case for integrated behavioral health. And Dr. Burdett helped us facilitate those sessions. We built the business case, took it to the board, got it approved, and then went and were able to raise the funds to do our very first integrated behavioral health pilot. And the goals of that pilot were around universal screening for depression, anxiety, and substance use disorder, being able to do brief intervention right there as, in the office, care coordination, increasing patients' self-care skills, and reducing total cost of care. And that first pilot was 10 practices that had about 42,000 adults. And I give a shout out to our funding partners. I think Lisa mentioned that we were a SIM state, and we did surely receive some funding from our SIM grant, which we appreciated. Also, Tufts Health Plan and the Rhode Island Foundation really provided some significant funding over a 3-year period for this pilot. And so I'm going to turn it over to Nellie to tell you what that pilot program looked like, and then we'll go from there. So hand it off to Nellie.
Thank you, Deb. And hi, everyone. So I am going to walk you through here with all the multiple hats that I wear, hopefully a sense of how the arc of what we've done in Rhode Island around integrated behavioral health has been. And there's a lot of content in these slides because I hope what you'll be able to see is we've really gained the momentum and traction in our state, which is like 1 million people condensed in a really, really small area. So I think part of it has just been geographically very different from Arkansas, and really interesting to hear about some of the rural pieces, which in Rhode Island, I'll make a joke, if people have to travel more than 15 minutes, you will hear them talk about how it's just too far and like more rural. So we're very, very different probably than the challenges that are experienced in truly rural states. That being said, I'd like to sort of walk you through this as a pretty close to a timeline in order of how our initiatives went, and just give you a sense of where they started and how they grew. So the first initiative that we began was a 3-year program that had 2 different cohorts based on what you heard Deb just describe. And some of the key places I think that really stood out were we had these identified practice facilitators trained in integrated behavioral health. And in this piece, it was only me, but then we continued to train others, which I'll talk about in a bit. And so what the practice facilitation allowed was a monthly check-in with every site around how do you support culture change, what are the workflows that need to change, and how does billing then support that. Universal screening was a big piece to that, right? So that population health approach, and what are the 3 most common diagnoses in primary care? Depression, anxiety, and substance use from a behavioral health perspective. So we put in a practice with deliverables that we were able to incentivize around screenings getting to a certain level, which I'll show you about in just a moment. Every practice had to have that embedded IBH clinician. So a little bit of what you heard from Arkansas about different models, we truly went for the integrated model. This wasn't co-located or collaborative, so they were truly embedded within. There were warm handoffs, pre-visit planning, and huddles. They were a part of the organizations that they supported. We had 3 PDSA cycles in these 3 years that focused on getting screenings to a certain rate, focusing on those patients that went to the emergency room a lot and might have had a behavioral health overlap, as well as chronic conditions, chronic medical conditions that had a behavioral health counterpart. So really encouraging practices to focus on how they are unique. So each practice had to have this content for their PDSA, but they could approach it in any manner. We had quarterly best practice sharing, and I have to tell you, this was most practices' favorite piece of this, getting together the entire group across the state and discussing not only what changes were happening from a data driver perspective, but also hearing from content experts and just sharing what's working well, what's not. And like I mentioned, we had infrastructure payments, as well as we incentivize screening targets, because this is a lot of work that, you know, to make this kind of systems level change, that even though the billing piece, once you provided a direct clinical service, could be reimbursed, all of the other pieces could not. And it was a significant amount of meetings and training. So we really wanted to make sure, with the help of our payers and our funders, that we could help incentivize financially. So just to give you a quick sense, I'm not going to read through this, but these are some of the qualitative evaluation pieces we heard after this. You know, really providers loved it. And, you know, we had practice coordinators even. We had providers from the behavioral health perspective say that they were all so surprised by how much of a positive impact that it had and that they weren't expecting it to have. But about the utilization and the screening outcome results, I really wanted to spend some time on this. So let me draw you to our first PDSA across both cohorts. So what you can see here is just really quickly a snapshot of screenings and where we started. And remember, there were 2 cohorts, so you can see them right here in these 2 arcs. Most primary care sites were already doing depression screenings. So you can see up here, this blue line at the top, most were already high, and that stayed pretty much, you know, the same. But what you can see was anxiety and substance use screening was new to the primary care practices. And you can see that over the 2-year period, but really well before, you know, I would say it took a good year to really get up to the same levels as depression screening was. But that's how long it took for anxiety and substance use screening to get deployed across the primary care practice, pretty much from a place of them only doing it here and there. So then what you start to see when we looked at this, and this is from the all payer claims database, is a real shift in what we were able to see across this time frame. And so what I'm going to point out to you is that this top line here, this red line, is pretty much a group in Rhode Island that is not part of CTC. They're not patient-centered medical homes. This was the cost per member per month, you know, across the same time frame, just to give you comparison. So you can see from $869 per member per month all the way up to $881 per member per month. Now, what you start to see when you participate in CTC, just broadly, not with IBH, just as a patient-centered medical home, is this PMPM goes down quite significantly, right? You can see that it got to as low as $690 per member per month. This is without IBH. Right, so you know, you can start to see that you're getting a $65 per member per month, $61 per member per month difference. Wait, I'm sorry, I'm jumping ahead. So back up, just to the purple and blue lines here at the bottom. These are our IBH practices. So you can see they already started at a lower PMPM than just the CTC sites that had patient-centered medical homes. But look at what happened at the end of the 2-year initiative, the difference. We got down to about $595 per member per month. Now, again, we can't say that this is causative, so we can't say IBH was the reason for this difference, but what you can see is 47, you know, $43 to $47 difference PM between these cohorts doing IBH and the CTC practices. And then you can see it gets even larger when you compare, just to the non-CTC practices. I believe that's right. Yeah. Okay. So then keeping going on, we said, is this related to emergency room visits changing? And you can see across all of the practices here, everyone started off a little bit higher. In fact, one of the IBH cohorts in general started off as quite high, but you can see that there were reductions all the way down to the end. So IBH, emergency room visits were also going down at a little bit more of a higher rate than if you were just being like the adult comparison group, or the CTC non-IBH group was very, very close. So we engaged Brown University and did a little bit of a different, what we call matched comparison group analysis, just to see if we could further dig into what some of those differences were. So what you can see is these kind of, darker green, indicators were all statistically significant. And what you can see is between both cohorts, we saw a 12 to 20% reduction in ED visits that participated, that had the IBH, and a 25 to 50% reduction in office visits. Now the light green were all approaching significant, so really close, but didn't quite meet that statistical criteria. And then the only part we saw go up just a little bit in one of the cohorts were professional services. So that's kind of what you do when you want to capture specialists. And so it seemed like for this cohort, pretty much for everything else we didn't measure here, there was some increase in specialist appointments. And, I don't think we can say we quite understand what happened there, but it also wasn't an area we were effectively trying to alter. So it's not really quite clear with that. But all the places we were trying to alter, we saw the either statistical significance reduction or approaching. So, we learned a lot of lessons that we continue to apply. And some of those that we learned from the qualitative and quantitative evaluations and all our learning collaboratives were copays were a barrier to treatment. We had this double copay thing in Rhode Island, which I know is in multiple states as well. You meet with your PCP, you pay a copay. You meet with your behavioral health provider, you pay a copay. That copay was a specialist copay, just like your cardiologist or your podiatrist, and it was typically quite costly. So you put both of those together when you're trying to have people, have convenience, your BH and your primary care visit in the same day, and it ended up being quite a barrier. So we were talking about and bringing that to the group and kind of thinking through how do we change that moving forward. The billing and coding was also difficult to navigate. Primary care is not set up to understand mental health billing. And so in and of itself, trying to teach and to learn about that to primary care was quite a challenge. And then we really realized from a workforce perspective that, there was just me in the state sort of doing it. And so our ability to expand and be sustainable was limited by how much time I had. And I have multiple jobs, and as much as it's my passion, I didn't want the sort of growth of IBH in the state to rest on me. So really focusing on how do we create the workforce to have additional people with this content function as practice facilitators. In particular, sites said, we really need more time to ramp up. So 3 to 6 months, the sites told us would be ideal to just prepare. So before we come in as an entity seeking to help, can we spend 3 to 6 months around billing and coding, credentialing? How do you manage the EHR, the workflow, the staff training at the primary care site? And so we took that back and then changed our initiatives moving forward to allow for that. Post-pilot, we talked about a number of actions that needed to happen in terms of workforce and really an alternative payment model, as well as some legislative action, and then some small practices that thought that maybe they could benefit from community health teams more than IBH, actually, because they were a little too small to bring on full IBH. So we took all this and then started to build the next series of initiatives. And what we were able to do is a number of things. And as I go through this slide, then I'll pass it back over to Deb to talk about some of these. But how we address copays is we included OHIC, our Office of the Health Insurance Commissioner, really engage them and then set along, you know, a statewide initiative that effectively removed the double IBH copay when and if it happened on the same day as the primary care visit. We also created a cheat sheet from the billing and coding perspective across all payers, got all payers to line up and make sure we were correct in that, and really bring in OHIC again to make sure that that parity was occurring across all payers. Very, very important. And then we created a novel training program. And I'll talk a little bit about what that is, but as far as I know, it's the only in the country that is training what I'm calling integrated behavioral health practice facilitators. So these are the folks that can come in and really from a content perspective and a leadership perspective, help primary care practices get from where they are to where they want to be for integrated behavioral health. So Deb, if you want to talk about the state policy piece, and you're muted. You might want to. Yeah.
Thanks. Okay, thank you. So I can just jump in on this for a bit. I think one of the things that structurally really helps us a lot is, you know, I mentioned that we're co-convened by the Office of the Health Insurance Commissioner, and the work that we did through the SIM also was something that at the end we were able to present a report to the commissioner and say, this is what we learned. And, you know, the barriers that, you know, we identified through the Learning Collaborative, as I mentioned in the chat, some of those were things that we could solve for as a, you know, either as a content expert or as a group. But some of them were things that we needed to bring people in to, you know, advise, like 42 CFR as an example was an issue that came up early on. But in the end, there were some things that bubbled up that really were more regulatory or, you know, issues that really needed to be, you know, addressed. So the copay issue, the double copay issue was something we couldn't fix. So having OHIC be able to, you know, look at our results, and then, you know, they had made, and to this day still do have IBH, you know, behavioral health as a priority for the commissioner's office. They convened a sort of a policy group open to the public and brought in some consultants to help drive through the process for them, but to really sort of make some recommendations that later went into what we call the affordability standards. So each periodically, you know, not every year, but every few years, OHIC will update what they call their affordability standards. And those are really standards that are promulgated by OHIC and relate to the commercial health plans. While Medicaid tends to sort of mirror a lot of that, but they do regulate. OHIC regulates the commercial plans. And so in the affordability standards effective this January, there are no more double copays on the same day for a primary care visit and behavioral health visit at what they're calling a qualified integrated practice. And that's a practice who has either gone through our program or has gone through some other kind of program that they can demonstrate, or has their NCQA-BH distinction. And so, you know, it's starting to set a bar for, you know, practices to go beyond patient-centered medical home, get their NCQA distinction, or go through a training program. And if you've done that, then you are a qualified BH provider, and you do not have to charge your patient the second copay. So that's a really big deal for us. And then as Nellie mentioned, you know, we did a lot of work to pull together all the codes from the different health plans and review them, and then OHIC validated them with everyone. And so the hobby codes were reimbursed at parity. And so OHIC was able to sort of really drive that home as well. And then we made the recommendation, and in fact, this went through, that the screenings, the, you know, depression, anxiety, substance use screenings be considered preventive. So there's no cost share for that. And that got written into the affordability standards as well. So, you know, that is kind of how I think we feel really fortunate to be able to, you know, have that kind of weird position that we're in. We're sort of the boots on the ground, but we also, the work that we do can inform state policy and help drive some of the barriers really to comprehensive primary care. Thanks.
All right, thank you, Deb. So let me talk a little bit about workforce development here and how we created this training. So this is a slide that shows our first 3, and we've since trained more, but in particular created a training that at first was 6 months of a didactic and experiential training, included people who had many different backgrounds, as you can see here. And, we sort of got them to have little internships even at sites over a 1-year period to make sure that their training, was at a level that was consistent with the quality we wanted to provide. And with, support of our foundation, our Rhode Island Foundation, Rhode Island College, we're really able to get this off the ground. And now some of these practice facilitators continue to work with us with, on ongoing initiatives. So, as we were growing this, we realized we had to have it spread. And then with Tufts Health Plan funding, we're able to train an additional 3 local IBH practice facilitators, but realized there might be some need nationally for this. So got funding to create an online web-based practice facilitating program. It is, open across the country. And, we have, John Snower, JSI, really helped us frame it in a way that was focused on adult learning. There's some live filmed versions that I present. There's homework assignments and monthly conference calls, but it's essentially self-paced. And even has a shadowing option if sites are interested, with some CEU credits. And so we're really excited to actually just this year include a 5th module that we're adding to it, where we really focus on sustainability. And why I thought I would mention it here is that we're focusing on NCQA behavioral health distinction within that. Because as of now, it's one of the very few that I'm aware of in the country that's providing an evidence-based way of assessing whether or not your patient-centered medical home has met a certain number of standards, right? So, we included it in our affordability standards. If you get this distinction, that sort of, vaults you to this higher level where you're eligible for all these, state incentives. And we hope that we get to a place where we can start talking about alternative payment models, because you can measure, having completed this, that another entity is saying, yes, you are in fact doing the highest level of integrated behavioral health. And interestingly, Rhode Island had some of the highest amount of practices that were meeting the behavioral health distinction when we met with our NCQA colleagues. So moving forward from there, we really wanted to test out and move out with more funding from United Healthcare. We had an adult IBH expansion model, and we really wanted to test, can we do this in less time? In less than 2 to 3 years. So we tried out a 1-year program, really leveraging the key learnings and resources. We added social determinants of health, SDOH, and had 7 practices graduate from that. Then, we thought we can't leave our pediatric partners aside. So with funding from, again, Rhode Island Foundation, United Healthcare, and Tufts, we tried a 3-year program that had 2 different cohorts and, really tailored to pediatrics, with a child psychologist as a practice facilitator and content expert. Really changed the screening measures to be relevant to the pediatric population. And then right now we are in our newest collaborative, which is a tele-IBH. And as far as I know, there's a lot of tele-behavioral health, sort of traditional initiatives going on right now, but really nothing around tele-IBH, which, as you've heard, Arkansas mentioned, is very different than standard outpatient. So this is a 1-year program that just started. We have 11 practices from adult through PD, and we're really focusing on how can you set up your tele-IBH in the midst of COVID, which you've probably already done, but make sure you're doing it at the highest standard and without really national guidelines on this. Within that, we're also incentivizing practices to apply for their behavioral health distinction, because there is a cost to it. And they get the same thing, and you heard me mention before, they get monthly practice facilitation. There are learning collaboratives and some technical assistance, and the incentives go up to $10,000 per site for completion. So I really wanted to kind of circle back and highlight PCHC, Providence Community Health Centers. And as you may recall, I'm also the Associate Vice President of Integrated Behavioral Health. And I started Integrated Behavioral Health at PCHC about 6.5 years ago. So I really wanted to share this. This is hot off the press data through our accountable entity, which in the midst of the pandemic was about 34,000 neighborhood health plan members. So from July 19th to July 2020. And I really wanted to showcase, you know, this is several years out past a CTC initiative and how much we've continued to be able to impact the per member per month. I mean, significantly more than even the immense gains seen with the CTC initiative. So what you can start to see here is that patients who use IBH services at PCHC are more likely to be classified as higher risk and have a higher medical spend. So about $50 PMPM more medically expensive. Now that makes sense because if you think about it, you know, medical, you know, issues are generally tied to behavioral health. And when you see behavioral health involved, you do tend to see medical at a higher cost and complexity rate. But here is where I think we were really pleasantly surprised. So what you can see here is for the patients at PCHC that engaged with IBH, that's this purple bar here, compared to those who didn't, within these 34,000 patients, we saw $123 per member per month less spend, right, on around their behavioral health. And then around RX, scripts and durable medical equipment continued decreases, $49 per member per month less. So even though they were a little bit higher in their general medical spend, you can see that we way then, you know, more, I think, made up for it with the reductions that we saw here. So, you know, essentially our main takeaways are, you know, we see integrated behavioral health and primary care working. We see it improving access, improving patient care, and reducing costs. We also see that on-site practice facilitation by IBH subject matter experts really is critical in supporting culture change for successful implementation. Like we heard Arkansas say, you can't just come in and say, you know, here's a provider, just, you know, do IBH and see how that goes. You know, there's a lot more that's needed to really help support the success in these initiatives. And I guess where we still feel like we would like to see more action is around an alternative payment model for integrated behavioral health and primary care, which we're in discussions around and we have been for many years, and continue in the workforce development. You know, so, you know, in pulling from some recent events, I wanted to try to draw a parallel to what we're experiencing now. And if we think about what went on in the Suez Canal, from my perspective, we could think about that tanker that was stuck as the healthcare system in a lot of ways, really hard to move, one little degree off to the right and the whole thing gets stuck, right? And then you know, just really kind of imagining that IBH is one of those diggers, right? Just one of those places where we can really start to dig out, I think, some of the places where the healthcare system just gets in its own way, right? So, you know, Deb and I are open to answer questions. You can also always contact us by email. And, you know, we're more than happy to, you know, we've talked to many states and many groups across the nation. And that's all that we have for today. So thank you.
Thank you.
Thanks very much, both Nellie and Deb, for a great presentation on some really important, innovative work. There's a little bit of chat that I just wanted to share. It looks like our colleague Pano pointed out that there's been some work in collaboration with Rhode Island College to provide training sites. So, I mean, this is a good example of really working to leverage what you got, you know, which I think is a really important piece. And then around the you know, the workforce issues, which is not a small issue. And I think for people in rural areas, you know, obviously that's a sort of basic understood. Of course, you just don't have as many people, therefore you don't have as many professionals in various roles. But there's still a shortage, specifically, as Deb mentioned, of licensed clinical social workers to work in integrated behavioral health in Rhode Island, where it's only 15 minutes and you have to stop for lunch, right? Is that what you said? So I think these are really important issues, but much of the country has been looking at the work that's being done in Rhode Island. So really very grateful for your presentation. We do have just a few minutes until we wanted to break for another quick bio break before we move on to our next discussion. Is there anyone else who'd like to either ask a question of our colleagues from Rhode Island, or have a comment, or any sort of final words from either Nellie or Deb? I have one quick question then. I'm going to ask the same question of you that I did of our colleagues in Arkansas. So thinking about the recent months, and now pushing over a year, around dealing with what really hopefully is once in our lifetime event, but how to the integration of some of the telehealth issues and really having to really improve access to people, with acknowledging that there's got to be a higher need now than ever before.
Yeah.
Just wanted to ask if you wanted to say a few words about that.
I mean,
ahead,
there's
Nellie.
a number. Oh, go ahead. I was gonna just
Yeah, go
mention
ahead.
our
I was gonna
IBH.
defer to you on that. I think you could.
Yeah.
Good perspective.
You know, I mean, I think it's part of the reason we obtained and asked for funding to focus on tele-IBH. So it's part of the reason that is the content of the initiative that we have going right now. We also have just a general telehealth initiative occurring in the state, which is more on chronic medical conditions. But within that, there was a space where a chronic medical condition could be, for example, ADHD. So there are a number of sites that are also participating in another telehealth initiative through some CARES Act funding that focuses on how chronic medical conditions are sort of presenting up now in the telehealth world. So, you know, I think our approach to it has been to really, you know, listen to what, you know, our sort of patient-centered medical home members are saying to us where they're struggling, and then line up our funding so that then we can offer them, you know, technical assistance and training in those places where there's gaps.
Thank you.
And then I see a question came in from Richard. Can you
Yeah,
speak
sure,
more
I'll
to
read it. Sure. Yes. So specifically asking if the practice facilitators that are engaged in the CPC Plus could be a potential source of people to fill those positions, or at least temporarily. And also, if you could speak more to the backgrounds that will be important to recruit when you're thinking about enhancing the workforce.
Yeah, you know, so all of the integrated behavioral health practice facilitators, in fact, have clinical, behavioral health licenses right now. And one of the requirements is you have to have worked clinically in the role to be able to, you know, even get the training. But they tend to be in a place where, you know, they've been doing the clinical work for some time already. And so some of them continue to do some degree of clinical work, but many are just in a, you know, place in their career where, you know, being the consultant is, you know, more where they're at. So from a recruitment perspective in the practices, it's really important, and we have a lot of resources on, you know, how to find the right fit, how to even advertise in a way that pulls for people who have an interest in integrated behavioral health. You know, we refer to a lot of our community partners and our, you know, sort of training sites who can, you know, help provide the training. But, you know, I think ultimately, what we're likely going to need to do is see schools start to have more training in this particular role, because I see it as getting larger and not specific to the pandemic, but just, you know, specific to where healthcare is going, and really making sure that, you know, people who go through their social work or counseling or psychology degrees have some sense of what it is like to work in primary care and what the health overlap can be, right? And then in that way, the training funnel kind of opens up a little bit. And then as we have more and more sites who are starting to look for these roles and really competing with a very small margin of people who are qualified. Now, you can train almost anyone to this skill set, but even with training, you have to have the resources on site and someone that can train. So everyone that comes to Providence Community Health Centers is involved in an extensive training. That includes myself and, you know, some others, and some love it when they try it, but some, you know, afterwards, you know, they try it and they say, you know, this isn't for me. You know, if you can imagine going to school and learning how to do, you know, cardiology, and then, you know, someone calling you up and saying, hey, would you like to try something different? It's still in medicine. It's not cardiology, like, you know, it's, you know, primary care, right? You know, now, could a cardiologist do primary care? You know, I'm sure they could, but would they want to? Would they feel like it was a good fit? You know, it's very different, going from very specific, right, to kind of more broad. And so that's what we're asking most mental health clinicians in the country to do. They're used to very specific training, and working in integrated primary care is very broad. You have to know a little bit about almost everything. You know, you have to know a little bit about pediatrics, a little bit about adult. It's just a much wider net. And for people who like that, you know, like to learn about a little bit of it all, it's really great. But some people really like to specialize, and they don't know it until they try. So that's a little bit of the workforce issue, I think, in the country too.
And Nellie, I just add too, I think, you know, part of the model that we implemented and tested, as you mentioned in the beginning, was having practices at this point anyways, that were large enough to have at least a half a full-time behavioral health clinician, you know, embedded in the practice as a part of the PCMH care team. So it's all about team-based care, and somebody who's really part of the team on the medical record, in the practice, accessible, you know, to the staff that are seeing the patients, and able to follow up with patients that obviously screen positive. So that's, you know, that's an important construct, I guess, at least for, you know, for how we designed the program and what we were able to implement. There's other ways you can do this. It doesn't have to be that way, but at the time we were putting this together, we thought this is like the model we'd really like to see. And so if we're going to pilot something, let's build the pilot around something like that. So that's the way we approached it.
All right, great. Just one more comment. I'd love to just make sure that people know that Pana Urakaris is also a very important part of the CTC Rhode Island team. Pana, welcome. Wanted to just point out that it's especially a challenge when you're talking about cultural and linguistic appropriate services, obviously, and that's true for everyone. It's a markedly intense thing in Rhode Island, obviously. Okay, well, wonderful presentation. Thank you so much for sharing your vast experience and expertise with the group. We're going to take another quick break for 10 minutes. We will begin promptly at 2:05 when Chris Barton from Horizon Blue Cross Blue Shield of New Jersey will be describing the experience they've had with their program. A series of 3 fabulous presentations working towards the integration of behavioral health with primary care. Once again, just a reminder, when you have questions or comments, please feel free to enter them into the chat. I want to make sure that anything that you have to say or ask gets addressed, and we monitor it closely and really try to make sure that everything gets said out loud, so we have this opportunity to interact with our speakers. So it is with great pleasure that I'd like to introduce Chris Barton, who has both an MSW and is also a licensed clinical social worker. She is the Director of Integrated Systems of Care and Network Innovation at Horizon Blue Cross Blue Shield of New Jersey. She has decades of experience in New Jersey substance use disorder treatment and nonprofit social service systems. So really comes from the social service sector of the healthcare, specifically behavioral healthcare world, and has an interesting perspective on that. Also now working for a large and dominant insurer in the state of New Jersey. Previous to this position, she was the executive director at the Catholic Family and Community Services of Paterson, New Jersey. She has led the system of care, which is the ISC, for Horizon through a successful pilot that she's going to be describing to us, and is now overseeing statewide implementation of that program. So we're getting a chance to hear about some of the theory and then obviously the experience with implementation of a program. So with that, as you can see, she's already shared her screen, and I'm going to hand over the mic to Chris.
Thank you so much, and thank you for the invitation to join you all today to talk about integrated care. I wanted to add to Lisa's introduction that one of the reasons that I was hired at Horizon was because my primary language is provider speak as opposed to insurance plan speak, and Horizon was very interested in making sure that the voice of the providers and the experience of provider practitioners was included in the BH team. So I'm going to walk you through Horizon's Blue Cross Blue Shield's journey toward integrated care from the macro system perspective on through the Integrated System of Care program, the ISC. And along the way, I'll give you sort of an overview of that journey, our foundational principles, and how we've addressed integration from a product continuum perspective. And then I'm going to dive a little bit deeper into the integrated system of care. I'm very casual in my presentation style, so feel free to raise your questions in the chat and we can talk about them as we go along. Because I live in New Jersey, I tend to speak fast. If I get going too fast, don't hesitate to raise a hand and let me know to slow down just a little bit. So with that, let me tell you a little bit about our timeline over these last couple of years. By way of background, you should know that until 2019, Horizon had contracted with a vendor to manage our behavioral health services. But true integration of physical and behavioral health was really the catalyst behind Blue Cross Blue Shield's decision to end its carved out vendor relationship for behavioral health and ultimately to bring behavioral health services in-house for the first time in our company's 80-year history. Horizon's behavioral health team was born about 4 years ago when Horizon executives made the decision to hire my boss, Suzanne Kunis, who's the Vice President of Behavioral Health, to execute this vision. This chart is really a timeline of all that has been accomplished in these 4 years. Beginning in 2019, the then 2-member behavioral health team began putting together a strategy for integrated care. And that included things like piloting collaborative care models and peer support programs that were embedded in hospital ER departments, bringing behavioral health to the medical profession. Also developing value-based care episodes for behavioral health, focusing on anxiety and substance use disorder specifically. And then the very, very early planning and model development for what would become the integrated system of care. That was back in 2018. In 2019, our efforts evolved and included planning the transition to insourced behavioral health services from the contracted vendor. We also began developing and formalizing a product continuum that would address behavioral health needs at all stages of a severity continuum. We were also working on developing a strategy to evaluate performance and implement value-based programs for behavioral health. And we started implementing a pilot project for the integrated system of care in July of 2019. Late in 2019 and early in 2020, we're all about insourcing our behavioral health business. By the end of December 2019, we had the government business, Medicaid business in-house, and then in 2020, we brought in the commercial business. The rest of 2020 was focused on completing the pilot project for the integrated system of care and implementing our statewide expansion. We went from 1 county to 5. We just launched an RFP for another 7 counties, and we'll have the whole state in by the end of the year. And then all along the way, we've talked about continuing to grow our product continuum, and I'll talk more about that in just a minute. But these are our foundations of integrated care. There are really 3 main themes in our approach to integrated care at Horizon Blue Cross Blue Shield of New Jersey. The first is completing the insourcing of behavioral health services. Horizon recognized that it was ineffective to manage physical health without also managing behavioral health for our members, and we began an almost 2-year process of terminating our vendor contract for outsourced behavioral health. It was formerly contracted with Magellan, but right at the beginning of the transition was contracted with Beacon Health Options. And so we executed what we call a lift and drop. We took all of the business out and brought it inside. That included hiring about 200 staff and developing all of the systems and processes that had been outsourced for decades. It was really building a new unit within Horizon Blue Cross Blue Shield of New Jersey. again, all of the government business, Medicaid was insourced in December, and the commercial business came in at the end of March 2020. This actually happened 2 weeks after quarantine began, and it was executed virtually. I'm still in awe of the people that made that happen, but we were training new staff and really distributing even equipment so that people could begin their work from home all while we're trying to lift and drop this new venture. And so behavioral health is officially 1 year old now at Horizon, and really, I have to say, MMA is doing really well in terms of continuing to refine our systems and grow our products. And so the second piece is really about the continuum of resources to meet our members' care needs, whether they're very mild to moderate behavioral health concerns, all the way up to severe conditions that are life-altering and impairing. Horizon has resources to meet all of those needs, and I'll talk with you specifically about those in just a second. The third piece of our foundation to integrated care is the integrated system of care, which is a special program specifically for our members who have serious mental illness and substance use disorder. This is a population that has very complex care needs and often have undiagnosed or diagnosed but untreated medical conditions that may lead to shorter life expectancy. Through the ISC, a behavioral health provider is sort of quarterbacking the member's care to address physical health, behavioral health, and social needs. And I'll talk about that program in just a little bit more detail. But first, let me show you our product continuum. So let me orient you to this slide a bit. Across the top, you'll see a continuum line that goes from low to high. And underneath that continuum are sort of the evolution of conditions from preventative and whole health models all the way up to serious mental illness. The lower you are on the severity spectrum, the more self-directed your care is, while on the higher end of the spectrum, the care needs tend to require more structured programming and services. At the low end, we have preventative care and whole health interventions. These are things like website tools, webinars, training, self-assessments, and other digital tools that are focused on general well-being and mindfulness and meditation. When you move up into the mild to moderate needs, then we're talking about, again, self-directed but computerized cognitive behavioral therapy programs. Something that's available anytime, anywhere at the click of an app. Moving into the rising risk category, we're talking more about virtual therapy and coaching programs. Telehealth support has become big this past year, as the other presenters have addressed, and developing capacity within primary care practices and physical health networks to deliver deliver behavioral health care within their four walls. So empowering our medical specialists to address behavioral health needs as well as medical needs. And then as you move on into the substance use disorder and serious mental illness, these again are areas that require more structured interventions, where you see medication-assisted treatment, important to address alcohol use and opioid use disorders. The integrated system of care, which is specifically for clients with substance use disorder and serious mental illness, falls into this category as well. And then we've also developed peer support programs to help folks who have substance use disorder specifically. We're going to be growing this over the next year to help address mental health conditions as well. So we look at behavioral health on a continuum from the low severity to the high severity, and we're trying to develop programming that meets the members' needs where they are, not fit them into a box of any sort. So these resources are available to our members. They're also available for our physicians to refer their members, refer their patients to these services when they're available through their covered health insurance plan. And then moving on to what I like to consider our crown jewel, because it's kind of my baby, is the integrated system of care. So the integrated system of care addresses the physical health, behavioral health, and social determinants of health needs for our members, again, with serious mental illness and substance use disorder. The ISC is a part of the core offerings for the Horizon Blue Cross Blue Shield of New Jersey. So any of our members who are fully insured in our commercial book of business, fully insured, and the ASO groups all have this integrated system of care program available to them. The ISC is connects physical health providers, behavioral health providers, and social determinants of health providers on a regional basis to work collaboratively to help members with these conditions. Now, the population with serious mental illness and substance use isn't a very large portion of our membership at Horizon. It's really only about 5% of our membership. But these conditions are very, very complex. Members with these conditions tend to be frequent users of hospitals and ER visits. They tend to use higher levels of care, and in some cases, they tend to go out of state to residential treatment programs and detoxes, which leads to a whole host of other problems. But these hospital ER visits, higher level of BH care, they all drive up the cost of care. And in many cases, they don't do much to help these members address their behavioral health needs. Here in New Jersey, the typical per member per month cost for a member with serious mental illness or substance use disorder is in the neighborhood of about $1,500 per month. And so this is a population that draws a lot of attention, particularly in value-based arrangements where behavioral health risk is shared. Then we're looking at developing programs that are going to reduce those medical costs. We believe that helping these members access high quality and comprehensive care will ultimately put them on the path to recovery and will reduce the utilization that's driving up the cost of care. But there are many barriers to high quality integrated care. And I'm sure these have been addressed several times in this meeting today. There is stigma related to substance use and mental health disorder. There are fragmented service delivery systems, and even siloed care where traditionally mental health and behavioral health have been delivered separately and with very little crossover between the two. Heck, even in behavioral health, their mental health was treated separately from substance use disorder, and never the twain shall meet, sort of. It wasn't until 10 years ago or 15 years ago that we began talking about an integrated behavioral health care where you could treat both mental health and substance use disorders within the same setting. And so drawing on broad base of evidence-based practices, including the behavioral health homes and the certified community behavioral health clinics, and some of the work that's been done with the Medicaid population and research and demonstration projects, we sort of reimagined the delivery system for clients with SMI and SUD, and we developed this virtually integrated community of physical health, behavioral health, and social determinants of health providers. And we've added what we call an integrator. Think of them as a quarterback to help coordinate care on behalf of the member so that members don't have to navigate systems on their own. They have somebody advocating for them and helping them to get through it. Okay, this is sort of a picture of our integrated system of care. Remember, this is a model for serious mental illness and substance use disorder. I think it's sort of a step further along a continuum of severity than the previous presenters were talking about clients with mild to moderate mental health and sometimes substance use disorders. But what we learned was that many of our clients with SMI and SUD don't have primary care relationships. Or if they do have a primary care relationship, they're very compartmentalized in what they talk with that primary care provider about, and often it doesn't include their mental illness and substance use disorder. So some of the reasons that we have developed, again, we talked about the fact that it was a very high acuity group. There's a very, very high rate of recidivism and a frequency of using high-cost services. But also, again, many of these members have undiagnosed or diagnosed but untreated chronic medical conditions that are contributing to shorter life expectancies. And we know that there are systemic barriers, including stigma, including fragmented care for clients with serious mental illness and substance use disorder. We thought that these were barriers that were systemic but addressable, and that by addressing them, we could impact outcomes for our members. And I think you'll see that we did that. One of the key strategies in addressing accessibility was to make the behavioral health provider the center of care. So many models of integrated care have been built around physical health providers, and there's an appropriate place for that. But at least, as I said, for our clients with SMI and SUD, we didn't find that those primary care relationships existed or weren't expansive enough for the members to be talking about their mental health and substance use concerns with their primary practitioners. So we moved the center of care from the physical health provider to the behavioral health provider. We felt that the behavioral health provider was going to be more experienced in working with clients with SMI and SUD, and that they were going to have the staff and resources available to meet the demands of this population. It's a population that has frequent visits, frequent inquiries, and they often have a whole host of non-medical and non-behavioral health needs, frankly. They're often food insecurities, housing insecurities, transportation concerns. All of those things impede the client's access to care. And so we located the ISC in the Behavioral Health Center. Again, this is a virtual collaborative care relationship. It is not co-located. But this relationship between the primary care physicians and the ISC behavioral health provider is bidirectional. So primary care practitioners may refer into the behavioral health center clients who they identify as needing ISC care, clients with serious mental illness or substance use disorder. As well, the ISC behavioral health provider can refer to a primary care practice who is known to be friendly to the population that we're serving. I think if you think of this population as having its own unique culture, there's a cultural competence that comes with working with clients with SMI and SUD. And so we wanted to establish relationships with primary care practices that were friendly to this population as well. And so there's this back and forth relationship between the primary care physicians and the outpatient behavioral health center, where PCPs are referring to the behavioral health center. The ISC behavioral health center is referring to primary care practices. They're sharing information back and forth about the client. The ISC behavioral health provider is monitoring clients on a monthly basis and reporting to the primary care practice about what's going on, participating in shared decision-making about next steps for the client, and addressing an integrated care plan. In the meantime, the behavioral health center is also delivering behavioral health treatment. They could be treating a client either just therapy, they could be seeing a behavioral health prescriber, they could be in one of the structured intensive outpatient, partial hospitalization, or partial care programs that the behavioral health center runs. I talked about the fact that they're conducting monthly wellness checks. Our care navigators at the integrated system of care behavioral health provider are oftentimes taking clients to their specialist appointments. We've seen members just kind of paralyzed with not knowing what to do next. They see their primary care physician, they talk with the nurse practitioner, and they are given a referral, let's say for a diagnostic test or to see a specialist, and really don't have the wherewithal to make that happen. So our care coordinator at the behavioral health center is walking alongside them, sometimes walking with them into the provider, getting firsthand information about follow-ups and outcomes of testing, and helping to facilitate that for the member as well as for the primary care practitioner. And then the last piece is that they are addressing social needs, supporting the member in, again, obtaining transportation or many cases, they're providing transportation or they're using Uber Health. They are tapping into their existing resources to meet social determinants of health needs. In some cases, the behavioral health practitioners have food pantries and they're supporting members' food insecurities in that way. They're connected with local housing authorities and are helping clients to get into low-cost housing. They're also tapped into workforce development, so they're helping clients to develop the resources that they need to find and get a new job. Okay, let me share with you a couple of some of the outcomes from the Behavioral Health Project. I mentioned to you that Horizon conducted a pilot project for the integrated system of care between July 2019 and July 2020. Our integrated system of care partner, we chose one trusted behavioral health partner in Monmouth County, New Jersey, and one trusted behavioral health system in Monmouth County, New Jersey, and together they enrolled over 500 members in that 1 year period. During the pilot project, we used a standardized outcomes monitoring tool called the GPRA, the Government Performance and Results Act, which is a tool that many demonstrations projects use and was already existing in the behavioral health provider at that time. It was administered at admission, 3, 6, and 9 months post-admissions. And then we compared those responses, and we found that over a 9-month period, the members that were enrolled in the ISC had an 80% reduction in hospital visits. They had a 75% reduction in ER visits. They reduced their alcohol consumption by 65% and their illegal drug use by 90%. And they reported a 72% improvement in quality of life indicators. We validated this self-report with Horizon's claims data and confirmed the reductions in ER visits and hospital stays. And actually, in some cases, they were even a little bit higher than the self-report. But ultimately, all of this contributed to reductions in total cost of care. And I don't want to discount this last, change the screen. I don't want to discount this last quality of life indicator. This is really critical for clients who are experience substance use disorder and serious mental illness. For many of them, their lives have been greatly impacted by their disease state. And they've lost family, they've lost housing, they've lost all of the things that help to get them grounded. If they don't have a place to put their head at night, if they don't have food in their stomachs, it's hard for them to make good choices about getting and staying in recovery and managing their illness. So that's an important piece, a critical piece of the ISC. And I wanted to just share a couple of patient journeys with you to illustrate how the ISC works. I'm going to orient you to this upper left-hand corner over here. This is the ISC ecosystem. The pink represents physical health, the green represents behavioral health, and the gray represents social determinants of health. I'm going to give you some background information about the client, but then this is their roadmap, their journey. The pink, again, references physical health, the green is behavioral health, and the gray is social determinants of health. So Darlene sought treatment herself at CPC, which is our behavioral health provider, and based on her assessment was assigned to the integrated system of care. She had a long history of bipolar disorder too, and had been offered meds for quite a long time. And she was using alcohol to self-medicate. Darlene also had some chronic medical conditions, many of which were related to her chronic alcohol use and smoking, including hypertension, IBS, and GERD. Darlene had not seen a primary care physician in some time, so CPC connected her with a PCP practice that was familiar to the ISC and that welcomed patients with behavioral health conditions. The PCP and the CPC nurse practitioner worked closely to manage and monitor Darlene's physical health conditions. CPC also did a complete evaluation and started Darlene on both Vivitrol to address her acute alcohol use disorder and medication to treat her bipolar disorder. Darlene was engaged with her therapist and case manager at CPC, and she made good progress, but experienced a relapse several months into her treatment. She re-engaged immediately and was able to get back on track. Now Darlene has been abstinent for a year. Her medical conditions have improved significantly. She got her job back and has reestablished a relationship with her son. Her mood disorder, her mood is great, and she's beginning to gain some financial stability. And she and her counselor are starting to work on her next goal, which would be to quit smoking. The next case is Mario. Mario was referred to the ISC in January 2020 through one of our PCP practices. He had a long history of alcohol use disorder and some physical health problems related to his drinking. Mario had just been hospitalized for a GI bleed related to his drinking and also had elevated liver enzymes, hypertension, and high cholesterol. The PCP practice worked with the patient and CPC's nurse practitioner to get the client set up with medication to address the most acute medical conditions, and the nurse monitored these monthly. Initially, Mario refused to stop drinking, so the behavioral health intervention was really a harm reduction intervention. Ultimately, though, over time with motivational enhancement intervention, Mario eventually made the decision to stop drinking and agreed to use Vivitrol to help him do that. Vivitrol has been very effective for Mario. He's coming up on 8 months sober and still using Vivitrol. He's attending therapy and working with his case manager on follow-up medical appointments. All in all, he is doing very, very well. This is all very promising. It's all very encouraging. We can see anecdotally as well as in the data that the ISC model is making an impact for clients with serious mental illness and substance use disorder. And so by the end of 2021, we expect to have the ISC program in all 21 counties in New Jersey and to continue to grow not just in breadth, but in depth in those counties and really orienting our physical health partners to what's available in the ISC, how it can complement their existing embedded behavioral health practices, as well as offset their total medical expense. And that's the Horizons Integrated Care.
Thank you, Chris. Great presentation and really a lot of detail that's incredibly helpful. There was a specific question that came from one of our colleagues, Victor Pincus, specifically wanted to know what kind of tool you were using as to stratify risk, if there was a standard tool or if you had a, what you're using to get some sense of where patients fall on the spectrum of need.
We aren't using any specific tool at the plan, at least. I think different providers are using different assessment tools, everything from PHQ-9s to GAD-7s to even crisis risk assessments. There are tons of tools out there. We're not prescriptive about what needs to be done and how to assess risk. Okay. For the integrated system of care, there's a whole list of diagnoses that qualify for the integrated system of care because we're trying to stay true to the model, right? But typically clients with serious mental illness are those that have significant impairments and who are frequent utilizers of high cost services. So we've included bipolar disorder, schizophrenia, schizoaffective disorder, even personality disorders. So we try to be as inclusive as possible with the criteria, but knowing that we want to focus on the clients with more serious impairments that are not well treated in collaborative care practices.
Standard. Okay, great.
I hope that helps.
Thank you. Deb Hurwitz, did you want to add to that discussion, or looks like you had a comment in relation to that?
Oh, I was thinking that maybe there was a question around the GIPRA and how you use the GIPRA.
Oh, okay. So the GIPRA is, it's been used in demonstration projects. I think it was one of the presidents, Bush maybe, that introduced the GIPRA as an outcome monitoring tool for federal demonstration projects. Mm-hmm. Our partner for the pilot project was one of the CCBHCs, which is a SAMHSA funded demonstration project, and they had that system in place right now. It's not a screening tool, so it won't tell us what the risk is, but it gives us a lot of information about where the client was and where they are at the longitudinal administration of the survey.
Yeah, we've been using it for our expert program, and from a
Yes.
primary care perspective, it's something like 25 pages long. So I mean, it was really onerous in terms of implementing it within primary care as a regular reporting tool. But you know, we have done it, and we are doing it. You know, not deep in primary care, but in other areas where we have to because it's required for you know, federal compliance with the grant. But it's quite a thing.
Well, I think when you're using it in the context of a demonstration project or as an evaluation tool, it makes a lot of sense, right? Because they want that level of detail, and the purpose is evaluation. But you can't use it on an ongoing basis in a therapy setting. It just we've switched to another instrument.
Definitely not. No, it's not. Yeah. But, you know, even to get primary care to participate in some of, like, you know, some of, for example, expert screening, when they looked at the tool, they bowed out. So we had to find other settings. We had to find other settings to, you know, do the expert screening that was going to be funded, and that tool was going to be required. But, you know, a number of the practices have, you know, at least in Rhode Island, they've worked, I think, through HRSA to implement expert, and that wasn't required, and they've done just fine. Just, you know, well.
Yeah, you have to ask yourself if you really need all of that information, or if there's another way to capture it. I agree.
It's always complicated. Well, speaking of information sharing, I have a question from Dr. Shonka in Ohio. And his question is if you've run into barriers with what information behavioral health can share with the primary care practices. And this is around protected health information and a specific question around whether there's patient consent required.
We did use patient consents. So HIPAA sharing of information, you know, we all know about. There's the additional requirement of 42 CFR Part 2 for substance use disorders. So we did consent each of the clients to share information with their primary care providers. We also had the added benefit of Horizon has a proprietary HIE, Health Information Exchange. All of our strategic alliance partners and major health systems report into HealthSphere, and our behavioral health provider was able to view HealthSphere and get just a wealth of medical information that we behavioral health providers have never really had access to. So they had a look into that history, and they've used that very well to help manage information, as well as even, I'll say, even confront inaccuracies, or inaccuracies isn't the right word, but it's going to escape me for a minute. Differing history that the patient is reporting. So we had a client just a week ago who said, no, I don't have any opioid use disorder. But when they logged into HealthSphere, saw that 2 weeks ago had been hospitalized for an opioid overdose. So it becomes collateral information for the social worker who's working in the ISE to talk with the patient about, you know, how to use this information and how to integrate it into their care plan.
Thank you. So we had a specific question from one of our insurer colleagues and asking if you implemented value-based performance measures for the ISE, and if so, what measures did you use?
We do have a value-based contract with our new ISC partners. The measures that we are looking at are priority access following hospitalization and ER visits, MAT engagement, primary care physician engagement, and readmission to hospitals, ERs, and behavioral health higher levels of care. So our providers, we've actually converted the providers to a case rate rather than fee for service. So they're on a case rate that's driven by the level of intensity of services that they provide, and then annually they'll get a performance incentive.
Thank you. And a point of clarification was just requested from Dr. Gibson that the ISC social workers are doing care management versus mental health therapy. So what roles are they playing?
The ISC provider is doing both. So the ISC provider can, three things really. They can be an APN care coordinator who's working directly with the primary care practice. There are behavioral health clinicians who are delivering therapy, and there are case managers who are addressing everything else.
So it's 3 different people or one person doing 3 different roles?
No, it's a provider practice, let's say, that has those 3 different roles within it.
Excellent. It's an excellent program.
Great.
It really draws on the strengths of behavioral health for the clients with higher needs. So again, I don't think there's an either or to the Rhode Island presentation and my presentation. I think that my population is just a step further along in that continuum of severity than maybe it can be treated in the collaborative care practice or the integrated behavioral health practice.
That's great. So I have actually a question around how the ISC team interfaces with housing in terms of looking, because obviously this is a population with high rates of homelessness and sort of churn in terms of their housing arrangements and how you address that.
The integrated system of care providers are I don't know if any of you are familiar with community mental health centers. They are the agencies that have been dealing with deinstitutionalization and finding people places to live for decades. So working with that provider population, they already have inroads into the, in New Jersey, we call them the continuum of care, folks who have access to housing vouchers and low-income housing and sometimes shelter vouchers if we need those, although those would be more of a last resort. But they have inroads, well-established inroads into those systems. And in some cases, some of our providers have begun leasing units on their own and renting those to participants, not just in the ISC, but in their programs. They become the leaseholder. And the landlords are happy with that because they have a secure leaseholder, and the tenants are being managed in the program.
Okay, thank you. Any other questions for Chris? Comments? Well, once again, thank you so much for an excellent presentation on a program that really is a leader. And it's really, I think I'm very pleased with the way these 3 presentations have complemented each other. Because I really feel like we're looking at a spectrum of certainly geography, sort of scale, looking at, statewide work versus things that are more narrow, rural versus urban. All of these things are part of the spectrum, and your focus certainly on people who really suffer from the most severe forms of mental illness, I think is a really fascinating component that often does get carved out, as we know. So thank you. Chris, a quick question. Are you comfortable with your sharing your slides with the group, or do you need to go back internally to okay that? I'm happy to wait on that.
No, I can share these slides.
Okay, great. So that answers my final question for everyone, which is that these slides and a recording that's being made and will be pared down for each of the individual presentations will be available on the Milbank Memorial Fund website on the webpage for the multi-payer primary care practice demos work. And we really are, just feel very fortunate to have the expertise and generosity of our colleagues who have shared their about so much information, rich information about the programs. Anybody else have questions or comments for today? If not, I think we can sign off a few moments early. It's been a long day for all of us, and I really thank you all for participating in this. I felt like I've learned a lot, and I hope all of you have as well.
I just want to say thank you for the opportunity, and it kind of speaks to the similarities that we have in our different locations, and there are national standards and evidence, but yet we're each trying to grow it in our own little area of the country. and in some ways having to learn ourselves how to make this work. And so seeing the best practices of other places is encouraging. So for this group to be able to exist and to share these practices is exactly where I think we need to go. And thank you for
Great.
helping us be involved.
Thank you so much, Patty. Appreciate it.
And Lisa, this is Deb. Just one thing I'd love to just ask Chris Barton. Our mental health authority is the group that's sort of leading the transformation work that you've described for the, you know, the specialty mental health sector, the community mental health centers. And I'd love to be able to share your slides with them. I think we have a call coming up in a week or so with some of those folks, and we try to keep tabs on each other while we're dealing with IBH, you know, in primary care. You know, they're dealing with the specialty, you know, clinics for, you know, the behavioral health, you know, centers and SMI, SPMI folks. So is it possible if they were interested, would you be available or willing to have a call with them just to describe your system?
Yeah, I would love that. In fact, I always prefer that to sharing just the slides, you know, so that I can speak to them. So yeah, definitely.
Oh, thank you. I'll mention that when we speak with them, but it's just incredible what you've done, and really hats off. Great job.
Great. Well, this is
Thank
exactly
you.
why this collaborative exists, this type of interaction between people who are part of the group. So thanks everybody for illustrating that. I really appreciate it. I'm going to go tell my boss pretty soon. Thanks everyone.
Thanks everyone. Thanks.
Happy
Thanks,
spring.
Lisa.
Stay well. We'll all the stuff will be up on the website within a few days, and we look forward to our next opportunity to gather together. Thank you.
Terrific.
Bye.
Thank you. Bye all.
Thanks.